So, good evening. Thank you very much for coming out to learn about shoulders. Again, my name is Jim Kelly, and I'm an orthopedic surgeon. My practice is here at the California Pacific Medical Center, and I'm part of the CPMC Joint Center. And the goal of these talks is to help educate the community about various forms of arthritis and their treatment. And tonight I'm going to be talking about treatment for shoulder arthritis. I happen to be a shoulder specialist. Now, there's a lot of things we can talk about with regard to the shoulder, but what we're going to be focusing on tonight is treatment of shoulder pain, and in particular, shoulder arthritis using joint replacement surgery. And so just a little bit about me. I studied chemical engineering in the University of Rochester. That's in upstate New York, for those of you who are mostly Westerners. That's out in western New York. I went to Vanderbilt University for medical school, and then probably the funnest part of my education was actually at the Naval Aerospace Medical Institute, where I became a flight surgeon and then spent about 4 years with the Marine Corps and F-18 squadrons, mostly in the Western Pacific. After that, I went to University of Missouri, Kansas City to study orthopedic surgery and become an orthopedic surgeon. And then I came here to CPMC, where I did my fellowship, focusing in surgery of the shoulder and elbow. I am part of an upper extremity clinic, and we're over in the Stanford building, which is the building next door here. Our clinic was started over 40 years ago by a gentleman named Sterling Bunnell, who's one of the pioneers of hand surgery, especially in the West Coast. We have 4 fellowship-trained surgeons, and we also have 2 trainees, 2 orthopedic surgeons who are actually training with us, and Dr. Kasim is here with us tonight as well, learning about the specialty shoulder and elbow surgery. And we have 7 staff members, and 3 of them are here tonight as well. So the question is do you have chronic shoulder pain, and what's the answer? What are some answers for you? Many people who come to me with chronic shoulder pain have a variety of problems, but among the most problematic are just using the shoulder in day-to-day activities, such as combing your hair, such as putting a wallet in the back pocket, or simple things like driving, picking up groceries, cooking dinner, things like that. And these may be things that are common to you as well. The symptoms that shoulder arthritis causes include things like chronic pain, chronic or problematic shoulder function, or a combination of both. So when I look at a patient, I'm really looking at them and trying to assess how much pain are they having and how much compromised function they're having, so I can help tailor their treatment program. Just a little bit about the shoulder. What is the shoulder joint? So the shoulder joint is made up of a ball and a socket, and you can see that up on the screen in front of you. And surrounding this ball and socket is a group of muscles that drive and move the shoulder joint. And those muscles are actually called the rotator cuff. And we won't be spending a lot of time talking about the rotator cuff, but that is also another source of pain in the shoulder. We're going to be talking mostly about the joint itself. That point where you see the ball and the socket meet, the shoulder joint, also known as the glenohumeral joint. The glenoid is the socket side and the humerus is the ball side, and again the glenohumeral joint comprises the shoulder joint. So what is arthritis? Well, arthritis really literally means inflammation of the joint. And when we talk about osteoarthritis, we're talking about arthritis of the joint that's usually caused by wear and tear. And on the left side, you can see what is a normal-looking ball, a normal-looking humeral head. And that's nice, smooth, and glistening cartilage. On the right side, you can see a very worn-out shoulder, a shoulder that's flattened. The yellowish area is where the cartilage has been completely worn away. And that large teardrop down below is a bone spur. It's a big bone spur. And because there's no cartilage, there's no protection for that bone, and that can cause pain by causing inflammation. So inflammation happens in the joint, and then patients develop pain. This is a video of an arthroscopy inside of a shoulder joint. You can see on the left the ball and on the right the socket, and you can see how glistening and smooth things look. in a normal shoulder joint. And that's the biceps tendon, for those of you who are interested, which I'm pulling down with a metallic probe. So there are some causes of shoulder pain and compromised function, some things that can create actually pain in the shoulder. Those include arthritis and fractures and dislocations. These are sort of ways that people get to having a painful shoulder. So again, what is arthritis? We've talked a little bit about that. Arthritis is simply loss of cartilage. Osteoarthritis is loss of cartilage, which results in pain because the joint is now rubbing bone on bone instead of having that cartilage covering. Fractures can actually cause arthritis. So on the left, you can see a diagram of a patient who, or diagram of a shoulder model where there's a crack through the humerus. And if you have a crack through the humerus, that can actually disrupt the blood supply and cause the bone to collapse and create what you see on the right, which is arthritis resulting from a fracture. People sometimes also dislocate their shoulders, and some of you may have dislocated your shoulder when you were younger playing football or baseball. And when that happens, that also injures the cartilage, and the long-term implication of that is that arthritis can develop. And this is one of the modes of developing arthritis. So how do you manage the pain of arthritis? Well, you can see this gentleman's just kind of sitting there unhappy, and that's how he's managing it. Well, there are a multitude of treatment options for arthritis, as you know. Those things can include just changing your activity level. In other words, not lifting so much, not reaching so much, avoiding the activities that you might like, such as tennis or golf. You can go to physical therapy, which to some degree can help out patients with arthritis, but I don't think is uniformly successful. Medications are often very helpful for arthritis, things like medications I'm sure you've all heard of, like Motrin, Naprosyn, Aleve. Those are the medications we call anti-inflammatory medications, and they can be very useful, especially in patients who have mild shoulder pain. Many patients come to our office visiting us to talk about their shoulder arthritis, and we offer them cortisone injections. And cortisone injections, again, are a good short-term option to provide pain relief. But again, the cortisone doesn't cure the arthritis. It simply does what all these other non-surgical treatment options do, which is alleviate the pain, diminish the pain, and help people deal with the problem of arthritis. A long-term solution, if patients have significant pain that is intolerable, that causes them to miss things that they want to do, that causes them to take medications that they don't want, and that causes them basically to have a life that they don't like, a long-term solution is a shoulder replacement. And there's a variety of different shoulder replacements that are available depending upon the particular problem that somebody has. The most common shoulder replacement we do is called a primary total shoulder replacement. There are other shoulder replacements, such as a reverse shoulder replacement or a resurfacing shoulder replacement, that can be used in specific patients that have particular diagnoses. So what about shoulder replacement surgery? I'm sure most of you have heard of and had friends that have had hip replacements and knee replacements. But shoulder replacement surgery, maybe not something you've heard of. Well, let me tell you that the shoulder is actually the third most common replaced joint outside of the hip and the knee. You can count on there being about 10 hip replacements for every one shoulder replacement done. But the shoulder replacement operation itself is an extremely effective management tool for the treatment of advanced osteoarthritis. I have lots of patients who come in and say to me, well, we heard that shoulder replacements really don't work that well. Well, let me tell you that that's absolutely not true, and we'll have one of my patients come and talk to you later this evening about the benefits that he had from having a shoulder replacement. So there are studies that prove that shoulder, and we have studies ourselves out of our office that show the success rate of shoulder replacement surgery to be just that and just as good as hip and knee replacement surgery. So what do you do if you feel like you might be a candidate for this kind of operation, this kind of treatment? Well, the key is going to your doctor and talking it over, because not everybody that has shoulder replacement, or not everybody that has shoulder pain obviously needs a shoulder replacement operation. Let's talk a little bit about the individual types of shoulder replacement that are out there. So this is a diagram of what we call a primary total shoulder replacement. And John, maybe we could pass around some of these models if you get a chance. We actually have some models here to show you what these devices actually look like. Essentially what a shoulder replacement is is a replacement of the ball with a metal ball and a replacement of the socket with a plastic polyethylene glenoid. This is what it looks like to replace the socket. Basically what we do is reshape the socket and then put a piece of polyethylene on the socket. And this is what it looks like after the device is implanted. So you can see on the left is an X-ray of a shoulder replacement with a metallic ball, which shows up very nicely on the X-ray. The plastic actually is radiolucent and doesn't show up on the X-ray. But this allows for very smooth motion of the shoulder after replacement. You can remember back to that picture I showed you with that very large bone spur. The bone spurs and the capsule is released, which allows a marked improvement in range of motion after implantation of a shoulder replacement. So again, this is a primary shoulder replacement. This is what we do for patients who have straightforward osteoarthritis of the shoulder. Now I mentioned something earlier that you probably have heard before. That's called the rotator cuff. The rotator cuff, again, is a confusing concept. It was confusing to me when I first learned about it. The rotator cuff is nothing more than a group of muscles that surround the humerus. So as you know, to be able to move your arm in space, you need muscles. So muscles attach to bone by tendons. And there are 4 muscles that extend from the scapula over to the humeral head. And those muscles surround the humeral ball. And where they attach, again, is called the tendon. The 4 tendons essentially form a cuff of tendon tissue around the humerus. And they allow you to rotate your arm and also lift your arm upward. Now, there are many people who have rotator cuff problems, and in fact, rotator cuff problems, advanced rotator cuff disease, can create shoulder arthritis. For patients who have arthritis of the shoulder and also have a massive or large rotator cuff tendon tear, there is a device that we use now, or a shoulder implant called a reversed shoulder replacement. And this is specifically used for patients who have a bad rotator cuff and bad osteoarthritis. And the real good news about this is that this implant actually wasn't available until about 7 years ago, and it really has transformed our treatment of patients with these kinds of problems. It helps not only patients with large rotator cuff tendon tears, but also patients who might have other complications related to shoulder replacement surgery. So again, it looks a little different. Why do we call it reversed? We'll take a look. You can see on the diagram on the right, the ball is now on the socket side, and the socket actually is on the humerus side. And this type of device will actually allow you to reach over your head even in the absence of having a functional rotator cuff. There are other forms of shoulder replacement surgery. One of them is also called the resurfacing head. This is a smaller, basically a cap that goes on the humeral head, and this particular replacement is mostly indicated for younger patients who don't have much deformity and maybe who have a little less arthritis. It's nice in that it's minimally invasive. We do it through a smaller incision, but it's not necessarily the best, even though it's minimally invasive. It has its place. So there's a variety of different shoulder replacement devices. As we went over the primary shoulder replacement, we went over the resurfacing head and the reverse. So if you have shoulder pain and you're contemplating surgery, how do you choose who you go to? Well, I think in a city like San Francisco, you have fortunately the luxury of having a number of very high quality medical centers with people who actually specialize in particular areas of the body. So shoulder specialists, or the specialty of shoulder surgery has developed since basically the 1970s, and my partner Tom Norris has been here for about 25 years and has built this clinic, which I'm now part of. And the thing you need to know about shoulder replacements is that not all of them are done by shoulder specialists. In fact, about 75% of them are done by non-shoulder specialists. But studies have shown that if you go to a surgeon, whether you're getting your hip replaced, whether you're getting your knee replaced, whether you're having brain surgery or stomach surgery, if you go to a person that specializes in that anatomic area, your results are going to be better. So I'd like to make a pitch for you that if you're going to choose to have surgery, especially if you're in a place like San Francisco, that you go with a specialist who's fellowship trained in that area. There is a direct correlation between volume of surgery and outcomes. And that basically what it is. Specialists in a particular area, if you go to a hip specialist, if that doctor is doing a lot of hip replacements, you're more likely with that doctor to have a higher success rate. And so that really is the value of going to a joint specialist. So what about considerations before surgery? If you decide to have surgery, what should you consider and what should you be planning for? Well, a few things that you should consider are medications that you're on. And again, normally what we do is have you go to your primary care provider to make an assessment of your health. You want to kind of consider what kind of things you might need after surgery. So for instance, if you have surgery, you're not going to be able to use your right arm and you're right-handed, you may need some help cooking. You might need some help with your food. You might need some help getting in and out of the bathroom. There are plenty of things that you can do in advance to plan this out, and our office, since we do take care of so many patients with these problems, is well equipped to help you in planning for your surgery. What do you expect? What's the surgery process like if you actually have a shoulder replacement surgery? Well, first of all, it's done in a hospital. It's done most commonly for shoulder replacements as an inpatient, and you usually spend about 2 nights in the hospital. The incision is about 5 or 6 inches long, and it's right over the front of the shoulder. Shoulder surgery takes place again in an operating room where everything is clean and sterile because we want to minimize the chance of infection. The operation itself takes about 1 to 2 hours. At a hospital like this, we have specially trained anesthesiologists, and we have just a small cadre of anesthesiologists who do our shoulder cases. The reason for that is because most of our patients get a nerve block so that the shoulder is completely numbed up both during and after the shoulder surgery. So when the patients wake up and they're in the recovery room, there really is essentially no pain. As the nerve block wears off, we have IV and oral pain medication to help manage that. We also have a specially trained operating room staff. Here at the California Pacific Medical Center, we do about 200 of these cases a year, and because of that, the operating room staff is very keen on what needs to be done, and they're very familiar with the operation itself. We have the implant systems in our hospital. We have a team of company representatives here to help us out and make sure that everything goes right for the patients who have surgery here. Post-operatively, we have a joint center here. We have specially trained nurses who act as a team to provide care for patients in the hospital. And this is a group of, this is 5 of our nurses who I pulled together this morning for a picture in their blues. Recovery post-operatively. Again, we usually keep our patients for about 2 nights, and most people are able to return actually to most of their daily activities, like dressing and brushing your teeth and talking on the phone within a couple of weeks. Usually not safe to drive until about 6 weeks, and the overall recovery is about 4 to 6 months. In other words, that point at which you've kind of gained, where you've gained most of the benefit of the shoulder surgery. We do send patients to physical therapy. That starts about 3 weeks. My favorite physical therapy is pool therapy, so if you're interested in shoulder surgery and you have available pool membership, that tends to be the best, most effective physical therapy for shoulder surgery. Total recovery time, as I mentioned, is about 3 to 6 months. So what are the outcomes? What should you expect after shoulder surgery? Well, primarily, what I tell my patients is that what we're shooting for is to diminish the pain. And you should expect to see a marked diminution in your pain after shoulder surgery. Secondly, we also want to improve your function. So we want to be able to restore your mobility so you can reach up and do the things that you want to do. Many patients who come in are complaining of painful pain at night. And that's a that's a very distracting, difficult problem to manage. And the shoulder replacement should allow you to sleep restfully at night. And we should also allow you to return to your daily tasks and activities. As with any operation, there's potential complications that can arise. Our complication rate is low for these kind of complications you're seeing here, such as infection or dislocation, postoperative fractures or failure, or postoperative fractures. The complication rate is less than 1%. The plastic, the polyethylene in there has a failure rate at about 20 years of about 10%. So the complication rate is quite low for this operation. Overall, the patients are quite satisfied. And among my practice population, most patients, once they're done with the operation, they're wondering why they hadn't got it done earlier. It's interesting, people talk to me about, well, how much pain do you need to have before you go through with it to have a shoulder replacement? And for those of you who have partners, or you have a wife or a husband, I oftentimes will say, well, let's just talk to your husband or wife or your partner, because they're the ones that actually observe the change in personality that their significant other will have because of pain. It really does change people's personality. And if you're sort of if you're a hard charger and you just kind of put up and move forward, a lot of times you yourself won't notice that your personality has changed and you become a grouch, but certainly your significant other will. So I think that's one element of your discussion chip that I really wanted to accent. I certainly learned a little bit about his driving habits and his falling habits. It's making me a little nervous, but.
Don't drive heavily sedated.
Okay. All right. So how do you decide to go forward with surgery? I think that essentially, Chip really gave us a lot of good food for thought in that regard. And the only thing that I guess there's a few things I could add. With regard to insurance, this is an elective surgery, but it's covered by traditional insurance. As far as long-term restrictions, in general, I recommend to patients that they avoid lifting, pushing, or pulling more than 25 pounds, because we're trying to preserve the degree, or the polyethylene. The polyethylene, if you will, you've seen what it looks like. It's a piece of plastic. It can wear out. For patients who are in their 70s or above, it's unlikely that would wear out in a lifetime. For people who are in their 50s and below, there's a good chance that there could be a second operation on the horizon. And between 50 and 70, it just really depends upon how much wear and tear is put on that shoulder. So 25 is kind of arbitrary, 25 pounds, but it's what we generally suggest. Success factors, what makes one person more successful than another with a shoulder replacement? Well, certainly there are some things about a particular patient, such as the quality of bone, which can make a difference. But I'll tell you that we can manage almost any quality of bone and still get a good outcome. The type and severity of arthritis, again, even with severe deformity, you might not be as perfect as the best person, but even with severe deformity, we can make a huge difference in patients' lives with the technology that we have available today, especially using the reverse replacement. The conditions of the muscle around the shoulder, if you have better muscles, you're going to probably have more strength afterward. But again, even if your muscles aren't working, there's still a lot of achievements that we can make with a shoulder replacement. Patients who are more robust, and when I say young age, I'm talking that's more of an attitudinal thing, more robust in the way that they look about things, have a higher activity level and higher health, will generally have better outcomes afterward. And as Chip mentioned, a commitment to rehabilitation is important as well. So our message is you don't have to suffer with pain if you have osteoarthritis, because we have a really good option for you, and we can improve your life. There are non-surgical and surgical options, so not everybody needs a shoulder replacement. Many people will do well for a period of time with injections or anti-inflammatory medications or modification of activities. If you've got kids or grandkids, and you've got a painful shoulder, you can still reach out and hug them and hold them. just like I like to do with my two kids up in Donner Summit in California. That's my email address. Email address is on my website, and my website is sfshoulder.com, www.sfshoulder.com. We've got business cards in the back. Can you turn on the lights, please, Dave? That's our phone number for our office, CPMC Joint Center, 1-800-637-2762. There are other specialists like me who perform hip and knee replacements as well, and that Joint Center line can direct you there. And so I want to thank all of you for coming out tonight. We really appreciate it. I want to especially be a big hand for Chip. Thank you very much. And I also want to thank CPMC Joint Center, Rob Seid, who's the Director of Marketing, who helped us put this together, and also Tournier is a manufacturer of shoulder implants, and they kindly provided us the handouts that you have here and also helped put this together. So thank you very much.